So our next speaker is Paul Pockros, is actually pinch hitting for Carrie Fournette, who had a family issue. She couldn't be here today, so he's going to be talking about the AASLD HCC Abstracts.
So I'm the only thing between you and the panel and the end of the morning, and probably the last thing you want to hear on a Sunday morning is talk about HCC. So fortunately, it'll be brief. Let's start with the abstracts from AASLD. I'm going to talk about two abstracts that have already been covered, so it'll help a lot because it's going to be redundant. We talked about this yesterday during the HCV talk on changing the threshold for evaluation of patients who have achieved an SVR who had cirrhosis beforehand. I'm going to go over the background slides for why we think that's important. Strategies to improve HCC surveillance, because we're not very good at that in at-risk populations. We're good at it in transplant programs because we have an army of people that will identify somebody that's got an LRADS 4 or 5 lesion because they get a MELD upgrade or a MELD exception. But other than that, we're not very good at it. The incidence of liver cancer in Nash and in patients without cirrhosis in Nash, because we know that occurs sometimes. I'm going to talk about GALAD scored again. We talked about that yesterday, but I think it's important because it's probably going to be our new standard of care. And then early detection of cholangiocarcinoma. Actually, Chris talked about that this morning, and changing classification for intrahepatic cholangiocarcinoma. So just to remind you of the guidelines for HCC surveillance. You're aware of this, but there are a number of guidelines. They all use ultrasound, and they all recommend about a period of 6 months. And all of them concur that patients with cirrhosis need to be screened. Some of them have added in hepatitis B carriers. But there's a difference in the guidelines. So that brings us up to EASL this year. Now remember, the EASL meeting was held in June, not April. So we've not had a post-EASL meeting since June. So I threw in these two slides from the EASL meeting because I think they're important. This is from Heiner Weidemeyer, and it's looking at a large registry in Germany where everybody puts in their data, all the centers in Germany. And they looked at patients that had been treated with DAA therapy who had cirrhosis to begin with, and they followed them for 5 years. So that's more data than the most of us have. And they were able to delineate those with no cirrhosis did fine and did not develop liver-related events or liver cancer over 5 years. But those that had cirrhosis had a decline in their outcome. The annual incidence of de novo hepatocellular carcinoma was 0.6%. So that falls below the cutoff we have of 1.5% for liver cancers and hepatitis C, but above the cutoff we have for chronic hepatitis B carriers. And that annual incidence was higher in the first year or two, meaning probably you missed the cancer in the first year. It was probably there, pre-existing, and then we picked it up. And then it was about 0.8%. So, and there were some predictors, males more likely to have this, in baseline hemoglobin, GFR, et cetera, and high alk phos. But at the end of the day, the bottom line is we still have a risk for liver cancer in patients with cirrhosis that get cured. And that's going on for 5 years. So the second study from EASL was a single center study, but a very large center in Italy, also looking at 5 years of data, and mostly males. They had a majority about age 65. Mostly were Child-Pugh A, but some of them were Child-Pugh B and C. And they clearly showed that the risk of liver cancer persists. Even in Child-Pugh A patients, it was about 1% a year, a little more than 1% a year. If they were child's pew B or C before they were cured, it was much higher. So that's the population we really worry about. Notice they had 50 deaths, and half of them were liver-related, half were not. So their conclusion was, like Heiner Weidenmeyer's conclusion, was that despite cure, patients with cirrhosis still face a significant residual risk of liver cancer. So that brings us to the AASLD meeting this year, and Jag Childwald from Harvard gave me permission to show this slide. And this is his data, and it's basically looking at the new HCC incidence threshold. And he importantly showed that if you use $100,000 per quality adjusted life year, it's still effective if you go down to an incidence of 0.4%. So that means it is cost effective. This adds to a compelling argument that two groups have published now. Our group published this last year in Clinical Infectious Disease, where we said, well, there still appears to be a risk for liver cancer. It's less than 1.5%. Maybe we should lower the surveillance guidelines. And last month, Mindy Nguyen's group from Stanford published a letter to the editor saying the same thing. So you've got two groups now asking AASLD to change that guideline. Hint, hint. Okay, let's go on to screening for pedicera carcinoma. We really are bad at this. So Amit Signal at UT Southwest looked at a mailed outreach strategy. It's not a bad idea to go out to all his patients with cirrhosis, and he found that that improves surveillance from 21% done correctly to 35%. Still not very good, but better than what we were doing before. And these are all the predictive factors, and they were all better with the outreach. So the truth is, if you look at how well we do this in the United States, we do a bad job, a very poor job. And I'm sure this is true at our center as well as others. If Mindy Nguyen from Stanford's been interested in this for a while, and she published this in JHEP this year, and looked at all the patients with cirrhosis, and the percent that get the correct screening is 10%. Another 20 to 25% get screening every 12 to 24 months, and another 20% get screening 25 months or farther, and more than half don't get anything. So that's bad. And that's why we have patients show up with an advanced cancer, they've already got portal vein thrombosis and all this stuff. And, you know, our own system is guilty of this. We put in orders for every 6 months for AFP and ultrasound, but if the patient no-shows, cancels, you know, COVID blocks them off, it doesn't automatically get rescheduled. There's no epic bump there. I mean, there's nothing, they can just get lost. So I try to bring patients back every year just because sometimes this happens, and they show up and I go, where you been? They go, well, blah, 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 but at least they didn't go 10 years without that. Likewise, they don't get labs. They don't get esophageal variceal screenings either, which is surprising. So we do a much better job at surveillance, for instance, for colorectal polyps than we do for screening of varices. So we could do a better job here. Now, what about liver cancer in Nash patients, those with and without cirrhosis? So this was also, Dr. Bahari gave me permission to show this slide, and what Dr. Bahari did was look at, retrospectively, about 50,000 NAFLD patients, and looked at a subgroup, about 750 of them that developed liver cancer, and figured out what percent had cirrhosis and what percent didn't, because we've all seen patients walk in and have a liver cancer, and they do not have underlying cirrhosis. So that's horrifying, and we've all been scared. Well, what are you going to do? You're going to screen 100 million people with ultrasound every 6 months? You can't really do that. So what they showed was that, well, the incidence of liver cancer, if you had cirrhosis, was 1.9%, which is less than that with chronic viral hepatitis, but still significant, 2% a year, over that threshold. But if you didn't have cirrhosis, it was 0.16%, so below that threshold. So I think it's probably not cost effective to screen patients with NASH that don't have advanced fibrosis or cirrhosis. They included, tried to include FIB-4 score too, and they used a FIB-4 cutoff that was pretty high. So they said if you had a FIB-4, that was above 2.67, your rate for liver cancer was 0.6% or greater, and if it was below 1.3, it was 0.09, so almost zero. So you could use FIB-4 as a surrogate marker. So I think that's helpful. Now, what about better markers for liver cancer? We currently are stuck with AFP, and we now also have AFPL3, which is an isoform of AFP. And we've had DCP, which, by the way, has been around for 40 years. And there's a bunch of other markers that have been tested in investigation. But I think we're at a period now where we're going to change the standard of care for screening for pedicera carcinoma. The GALAD score has been described before, and it's a formula. It's not proprietary, but it includes gender, age, AFP, AFPL3, and DCP, and this is the formula. And we've known for 5 years, this paper was published 5 years ago, looking retrospectively at a large number of patients in Germany, Japan, UK, and comparing the standard measures we have, AFP, AFPL3, DCP, and GALAD score. And they all showed the GALAD score performed better. And so the conclusion was that should be our standard of care for screening for liver cancer. But this was a retrospective model, and it needed to be validated in a prospective study. So that's what was done this year. Jorge Marrero from UPenn gave me permission to show these slides. He presented the phase 3 prospective trial that clearly has shown that GALAD is the best test, and that it improved, if they fixed specificity at 90%, it improved this sensitivity from 33% to 54%. So that's significant. And we don't use AFP because it really sucks. It's not very good. It's not very sensitive, but this is more sensitive, and I think it's compelling. So it's going to go to the FDA, and hopefully this will be approved and will be our new standard of care, and the payers are not going to push back on ordering the test. You can order the tests now, by the way. You can order an AFPL3. How many of you order AFPL3s? Yeah, we do them. You can order them. You can order DCP. Obviously, most of us just order AFP. But this will be, I think, somehow a calculation or a software addition, and hopefully it's going to improve our ability to screen. Right now we're using ultrasound, and if the AFP bumps at all, we move and do MRI. Now, importantly, Amit Signal from UT Southwest also presented a novel multi-target blood test that's being developed. And this includes 77 markers. Bob Gish talked about it yesterday. Bob's not here today. He went to the HepDART meeting, but I know he's very much in favor of this. That includes AFPL3, AFP, and DCP, but it also includes a number of other markers. And this appears to be even better than GALAD score, at least, or as good as GALAD score, but possibly better. And it's still an early stage, So there's no definitive data, but this looks like, if we go to a GALAD score, then perhaps we'll have even a better marker test. This will be proprietary because it's being developed by Helio, which is in Orange County. It's a biotech company. But this is what their specificity was. You can see it's quite high, almost 90%. And compared to GALAD score, et cetera, the overall sensitivity was higher, and the specificity was quite good. So more to come on that, we'll see. Now, incidence of cholangiocarcinoma. Chris talked about this morning, but I wanted to frame it for you by what we know about cholangiocarcinoma. So the majority, those of us that screen our PSC populations for cholangiocarcinoma know this is frustrating. I've got about 40 patients with PSC. I screen them every year with MRCP and CA19-9, and I really don't identify any early cholangiocarcinomas. Most cholangiocarcinomas that get diagnosed in PSC are diagnosed within the first year or two. So what that means is we missed it. We didn't know the patient had PSC, and they showed up with a cholangiocarcinoma and get diagnosed to have PSC at the same time. So usually they show up with a jaundiced episode or a high alk phos or itching or bilirubin, and you start working them up and you find PSC on a scan, but they already have their cholangiocarcinoma. So it's really after that first year that we're concerned, and you can see the incidence is pretty low. This is from Keith Linder. The CA19-9 helps, but only if it's really high. So it has to be above, the Mayo Clinic uses 169, but most people use more like 400 or 500. So the CA19-9 has to be really high, so it's not that helpful. So this abstract that Chris presented today is troublesome because it says, well, MRI, MRCP once a year doesn't help. And that's what I do. Anybody do anything differently? Are you going to do anything differently now? You're going to do the same thing, right? Everybody's shaking their head.
Because it's protection.
It's protection of the patient or the doctor?
The doctor.
Okay.
Because if you didn't make the diagnosis and you didn't do it, we all know you stand out.
Especially because everybody nodded their head yes. So I agree. So we're going to keep doing it, but this suggests it doesn't. That's why we're not picking up any bile duct cancers. We do pick up changes in the biliary system. We get nervous when the CA19-9 goes up, and we do send them for an ERCP with brushing for fish. And, once in a while we find a cancer. This was an interesting basic science abstract that basically proposed we change classification of intrahepatic cholangiocarcinoma. We bundle them all together right now as one diagnosis. And the behavior of cholangiocarcinomas is different, and we know that some of them do quite well. They go to transplant, and we know others have a very ugly progressive course and do not do well regardless. And they looked at mouse models, and I'm not going to go into the details, but what they suggested is there might be a better way to classify bile duct cancers so we can sort out who's a good candidate for transplant. We need that. So lastly, I'm just going to remind those of you in the audience that may not have been keeping up with the literature that Seraphinib is no longer the first-line systemic therapy for hepatocellular carcinoma. It has been for 15 years, but this study was presented, the I Am Brave study was presented 2 years ago. That's the Atizobev study, and it was published in New England Journal of Medicine last year, and it showed that the combination of Atizobev has a 6-month overall survival that is superior to Seraphinib, and they did not even reach a mean overall survival at the end of the follow-up period, which was 13 months for Seraphinib, so it kept going for Atizobev, and the progression-free survival was definitely better in Atizobev than it was in Seraphinib. So this has become the standard of care. It's been embraced by the oncologists. The NCCN guidelines this year have upgraded Atizobev as first-line therapy. Just a reminder. So that's really all I have for you today. The summary is simple. There's a need to update the HCC incidence threshold above the routine because it's cost effective. We do a poor job of screening for pedicera carcinoma. At-risk populations, we should do a better job, and we need ways to do that. The incidence of HCC in Nash patients, thankfully, is not very high if they don't have cirrhosis. GALAD score, I think, is superior to standard biomarkers and will probably be, hopefully, the new standard of care. Annual MRIs may not be that helpful for cholangiocarcinoma. Changing classification of intrahepatic cholangiocarcinoma may be helpful. And standard of care is now Atizobev instead of Seraphinib. I'm done.